As we begin 2026, healthcare leaders are no longer asking what is possible. They are asking what's sustainable. The last few years pushed clinicians to their limits. Burnout became common, documentation spilled into nights and weekends, and doing more with less became the default across health systems. So, what feels different at the start of 2026 is that now we both have tools and urgency to rethink how clinical work actually gets done. So, today's conversation is all about that reset. How ambient AI, population health intelligence, and responsible system design can strengthen the clinician workforce without losing the human heart of medicine. So I'm excited to start the year with Dr. Travis Byas from Solventum, whose work sits at the intersection of clinical care, health systems, and AI governance. Thank you so much, Travis, for joining TeqTalk. Really, it's a pleasure to have you here.
Yeah, thank you so much for having me, Jazz. I really appreciate it.
All right, Travis, before we actually go ahead and deep dive into the topic, why don't you tell a bit about yourself, how you started, your overall journey of career, and what exciting things you're doing now?
Sure. So my name is Travis Byas. I'm a board-certified family medicine physician, still practicing a little bit in the telemedicine space. And I am Deputy Chief Medical Officer of our Health Information Systems business at Solventum. Solventum is a new name for some people. It's the former 3M healthcare business. And we've been spun out as our own independent business for almost 2 years now, so people are becoming quite familiar. I started here about 6.5 years ago, actually, originally in a clinical operations consulting role. We were using our population health data to try to more quickly get to the root causes of problems that our large health system clients or hospitals were facing when it came to quality improvement initiatives. And so that was a lot of fun. I learned a lot. It was my first kind of deep experience into Lean Six Sigma and process improvement, and where I quickly learned how important change management was, which I'm sure you understand quite well. And then pivoted into, after this role, I pivoted in to be Chief Medical Officer of our Clinician Solutions business. We had acquired Immodal, which is a front-end speech recognition business. We have 200,000 physicians across the US using our front-end speech dictation tools, and now many using leveraging our ambient clinical documentation solution. And so I served as external-facing physician for that business, and now pivoted more to work under our global CMO to support initiatives across the HIS portfolio. And so that's everything from improving clinician efficiencies in the EHR to reducing revenue cycle inefficiencies, which is kind of our core business, and on down to really the whole goal is accurately and completely capturing the complexity of the patient population so that we can allocate resources to properly care for populations. And so I'm excited about a broad variety of topics, and Solventum has been a great place for me to learn and to, I guess, grow as a physician who interfaces with clinical leaders and folks who work for ministries of health and state health departments within the US.
Great. That's very impressive. And I'm pretty sure we are going to deep dive into some of the interesting facts, figures, and your experience on what's going on currently, the challenges clinicians have. And I know that there is a lot of work clinicians do, and we do not talk much about it. So now it's the right time we do. So let's deep dive, Travis. Over the past year, we have seen that nearly every healthcare leader I have been speaking to, whether it's a CIO, CMO, nursing directors, clinicians, or anyone, they have raised the same concern that we are running out of clinical capacity, right, before we actually run out of demand. So, and also as per AMA and WHO data, clinicians burnout has crossed like 60% globally. And I think admin burden still remains #1 factor in driving this. So this is all as per the stats, but what stands out to me is not only about the workload, it's about the moral injury as well, right? So you have been in this field from decades now. Would like to understand from you that what is the really driving factor for clinicians overload today?
Yeah, wow. There's so much there that could potentially be used to answer that kind of stem there. And I think one of the things you mentioned was the burnout stats among clinicians that the AMA cites. I think there was a report where the AMA was like celebrating that burnout had dropped to like 50% or something. Like, it
Oh.
actually improved a little bit in the last
Mhm.
year or two since the pandemic's kind of emergency phase. And I think just like you, I mean, that's hardly something to celebrate. And it's something actually we still need to be focusing heavily on. And there are a lot of reasons for that, right? You mentioned, I think, one of the things, which is simply demand. There are demographic shifts going on across the world from low income to high income countries where demand is simply outstripping the supply of health workers, and the health workforce is not growing near fast enough to meet that demand. And so there are a lot of the health workers currently in the health system are really, struggling to kind of keep up with serving this growing demand. And there are many factors and many frustrations there, right? And I think this kind of was all highlighted during the COVID pandemic, where, I mean, the amount of, obviously, patients were flooding hospitals across the globe, and health workers were just simply like, look, I'm in a stress situation. I'm putting myself and my family at risk. I mean, it's a very different type of job for many people. They put their heart and soul into training to be clinicians of all types. And so the pandemic was really rough. And then now, in 2021, 2022, people thought, okay, maybe we're going back to how things were before. But people have really recognized, I've got a lot of nursing physician friends, this is the new normal. We're not going back to some time period where the summers might be like a little lower census in the hospital, or clinic might be a little slower in the summertime because people aren't as sick. People are sicker. People require more healthcare services. And so we really need to be thoughtful about what kind of resources we're putting to that and what kind of policies we're putting in place to serve populations. Because what you mentioned about health workforce stressors, I think there are many of those, right? So right now there's a strike of registrars or residents, physicians in training in the UK. There have been multiple strikes in low-income countries recently of physicians and nurses. Physicians in the US are unionizing more than ever before. And so I think there's a recognition that not only is there's more demand, but the health workforce just needs more, right? They need more support and different types of support. The things that we did 10 years ago, we would offer residents yoga classes and free laundry services. Like, that is not going to solve the burnout crisis. And so one of the main areas of focus that you and I understand, I think, is that the health tech and the clinical informatics pieces. The EHRs that have been deployed over the last 15 years in the US has created this burden of, there's stats that show that for every hour I spend seeing patients, I spend 2 hours in the electronic health record. And that is completely draining, and not why I did not go to medical school to click the checkboxes and satisfy all the drop downs to chart how sick the patient is in front of me. And in fact, that has taken my attention away from the patient, focusing on the computer screen and documenting. And that's one of the core things we try to work on at Solventum, is how do we reduce that burden of the clinician in EHR, but still capture how sick that patient is, right? Because those patients, these populations, need different types of resources to care for them. I worked in the employer-based space in high tech for a couple of years. Those patients need something very different than the people working in downtown Oakland, California. And so there has to be a way to gather the data to, I guess, allocate the resources appropriately and differently to those populations. I think there's so much there we could look at from the questions that you asked, but I think what it comes down to is health workers are being asked to do more with less, and they're simply asking for the resource. It's not simply about pay. It's about being paid on time. There's a study just last week, 37% of health workers in low income countries have some kind of delay in a paycheck. Like, that will be demoralizing and will not motivate you to show up to work and do your best. So if we want professionals coming and serving like we expect from our health workers, we have to treat them as such. And mostly health workers just want a complete team to work with. You want a fully staffed team. If nurses and physicians are missing, like if there are multiple outstanding roles that haven't been hired, or you don't have the right support staff, you can't take care of your population the best way you know how. And I think that's one of the core frustrations, no matter what country, what context you're in. If you don't have a complete team, or you don't have the resources you've been trained on to care for the people in front of you, it is super demoralizing, as you mentioned. And then that causes people to look outside, either to other sectors or outside of their country, to look for different work, because it's not sustainable.
Yeah. Absolutely. I mean, there are so many points I would like to touch base on, whatever you have raised. To start with, you mentioned that, and we all know that healthcare workers, they have to take care of the complex patients. They have to meet the rising quality and, reporting expectations and navigate staff shortages, like how you mentioned. Most of the time they have to work on the same pace. When you have a team of 7 people, 10 people, and then when you have a team of 2 people, you still have to cover all your work. So it's a kind of stress overall. And on top of that, you have the admin work, right? And I think it spills over to the evenings and to the weekends as well. So the pressure is constantly increasing. We all know that. So tell me more. Do you think this doing more with less is not a good strategy, first of all, because it's hampering our overall system of healthcare workers?
Yeah, I think there's, in any sector, if you put more demands on people and they feel like they're drowning and they're not able to adequately do their job, they're going to start, looking for other types of work, or they're going to start raising the flag. Like I think strikes and labor action is probably like further downstream of raising the flag, but they're going to start escalating to their bosses, bosses, like, hey, we need more support. We can't keep, this is not sustainable, right? And so I do think we of course, we need to shift our expectations. There was a report 25 years ago now that talked about all of the human errors that cause harm in the healthcare system. So of course we need to pay attention to this, right? And I think there's a conversation, a time and a place to talk about, we've got to improve quality. We've got to improve safety for patients. There are systems we can put in place and target to improve that. But to do so, you need systems to support the frontline health workers, right? If you've got frontline health workers that don't have PPE during a pandemic, they don't have an EKG machine, in a clinic, they don't have access to antiretroviral therapies, in areas where there's a high burden of HIV. There's going to come a point where the health workforce is going to say, well, what they're going to be defeated, right? What's the point? And so I think there's a huge, it becomes heartbreaking when we put so much time and effort into our training. We want to serve populations. We want to serve the patients in front of us. And we simply don't have the tools to do that. So I think that becomes demoralizing. And I'm not sure if I'm directly answering your question, sorry, but I do think there are ways that are not, we don't need to double people's pay. We simply need to, tweak a few things, like, the younger generations want a different work-life balance. They want a different work schedule. I think you can make that. Some people want to work different schedules that could probably be complementary to each other. And so I think organizations, governments, whoever need to be, we can be a little more creative about how to solve this burnout problem.
Yeah, and whenever I talk to leaders like yourself, everybody has same common point, that there isn't any motivation, right? So paycheck, the point which you raised out, is one of the motivations in other fields. That's the basic thing. And that is the most important thing. So if that is delayed, or that is not even, done on time, or it is not as per the expectations, why would anyone would like to go to this field? They would start looking out for something else which is in demand. I think there is a lot to talk, and it is high time now that leaders at the government and across everywhere start thinking and start having some framework which will help healthcare workers to grow. Because
I think there's somehow there's this expectation on health workers that because we went through all this training and have this knowledge and we want to serve others, that we're expected to do things that in no other sector, we don't expect people to show up if they're not getting paid. But here somehow, because I've got the heart for taking care of patients, I'm supposed to show up without getting paid on time. Like that doesn't track. And like there are other things where, like, for physicians in the U.S., it's a little, we have, of course, we think we're special. We have a very different system than a lot of other healthcare systems, but people talk a lot about the pay for physicians. I also didn't have my first job till I was, 29, 30 years old. And I was in 6 figures of educational debt. We have different stressors and different incentives in this system that definitely affect some of our decision-making and behaviors. And so, I think we can't expect something unique out of physicians and nurses and then not treat them as such, not staff their teams appropriately, not give them the supplies they need, not maybe talk a little bit creatively about the schedules they might want. I mean, ultimately, it's about being responsive to patients and patient demands. And I think there is a way to get there with some organizational policy shifts, a few different priority shifts as we enter this new age of, yes, health technology's kind of been around, but it's getting, AI is just lighting that on fire as far as the sophistication is just taking off. And And I think there's going to be a way to do more with less if we think about it the right way. We're more sophisticated about how we use the human health workers and their creativity and their translation abilities to take care of the patient in front of them, now that we've got a lot of this AI and technology supporting us in the background.
Absolutely. And do you think the situation of healthcare workers is across the globe, it's the same? Or some places or some countries, you think that they are better paid off, they have better structure, better framework, or globally it's almost the same situation?
I mean, I think most people hold up the NHS as kind of this, star performer. Their physicians in training are on strike right now. So I don't think there are health workers that are like perfectly happy in one country versus others. I do think there are like anything, there are risks and benefits, there are pros and cons to working in different systems, right? And so, here, I think in the US, we're a lot more reliant on, more than half physicians are employed. So we're a lot more reliant on organizational policies and cultures, whereas abroad, you might be more susceptible to political shifts. If there's a shift in administration and priorities, there's going to be a major shift in your workday as a clinician, and that touches you more intimately in a UK or in East Africa, where I have a little bit of experience. And so, I think there's systems like Singapore that have public health and social policies that are just night and day compared to a lot of countries. You see, I've been there twice in the last year, and just the amount of green spaces, the amount of walking there, only like a small percentage of people own cars. Just certain little. It seems like a big shift, but there's some small policies that kind of force
making a big difference.
But for better or worse, healthy behaviors among the population, and they see the benefits from that as far as life expectancy, quality of life, things like that.
Yeah, completely agree to it. And you also touch based on the healthcare workers or clinicians, right? They spend a significant part of their day in entering data into the EHR, right? And that is not they are trained for actually. And that often means that more screen time, but less time with the patient, right? So this is why tools like ambient documentations are emerging nowadays to reduce the typing and let clinicians focus on the patient, because patients need the human touch. So how do voice-based documentation and AI-driven CDI like Fluency Direct and Fluency Align are really helping clinicians to spend quality time with the patients, because they need human interaction. Nobody wants. It is, I do not want any robot as a doctor. I want a human.
I think that's a key point, right? 10 years ago, I'm trying to think, 10 to 15 years ago, when I was entering practice, I would see my patients, I would bring in my laptop, and I'm literally typing and kind of looking at them, and I might look back at my screen, I might do something, but like as they're talking. And so if you're telling a story, I have a great example. 5-6 years ago, I had a young 22-year-old woman who came in. She was telling me about back pain. It sounded like just a typical back pain visit. And I kind of look up, and she's a little emotional, and I took a pause, and I said, tell me more about that emotion. Tell me more. And she said, well, actually, I'm homeless right now. I'm living out of my car. And, on first blush, and just hearing your story, I wouldn't have thought about that. But if I'm looking at my screen, I'm not able to pay attention to some of those nonverbal cues. And so I think that's why ambient documentation solutions, these AI scribes are so powerful, because, and this is one of those technologies that, so many technologies in the last 15 years, we've had to tell physicians like, here, this is why you should use it, and like convince them. This is something that frontline physicians are like they're telling their leadership, if you don't have this tool, I'm not coming to work for you. And so it's because, now I can just record the conversation. I can look the patient in the eye. Once we've recorded the conversation, within 30 to 60 seconds, that note is popped into the EHR, at least a draft for me to review. And that is it's better for physicians. And as you said, patients are loving it. I think early on, people were like skeptical that patients might be like, oh, AI is listening. But the fact that brings some of the human touch back and some of my focus back to the patient in front of me, I mean, that is really compelling for physicians, patients, their family members. And I think this is why this one has been such a powerful use case of generative AI to remove some of that documentation burden. Now, I'll say it doesn't remove all of the documentation burden, right? There's still a lot of discrete fields and other data that is required. So, but I think it's a huge step in the right direction to capture a lot of the narrative pieces, a lot of the historical background and context that sometimes physicians, I might be waiting hours before. If a patient told me a story 3 hours ago, I might be lunch break to type something or dictate something. I might forget some of that, right? So now we're actually capturing some of the more valuable pieces of the story the patient's telling us, and removing some of those administrative burden headaches that clinicians have.
Absolutely. And I remember, I have a small example. So patients like me feel so disconnected if the doctors are not talking really, and they are on the systems. And I can give you an example that when I was expecting with my first child, it was very first experience, right? And I had so many questions. And the doctor used to just keep on, writing on the system. And because of that, I tend to forget all my questions. I never ask questions. So I literally had to go and write down in the paper that I have to ask these questions. The level of disconnection was so much. And I'm glad that it is coming back to the connected systems and the connected feelings, especially with the doctors and patient. That is the most important, the human touch anyone can have. You also raised one point that technology has quietly pushed clinicians into, think into the check boxes, right? Which you're not supposed to do. And ambient documentations, they have the potential to flip that altogether. So as per you, what does ambient documentation change inside any exam room? Give me a couple of examples if you have.
Sure. I think that we've kind of talked about the power as far as bringing back the human connection. I think when we think about completely capturing the patient's story, I think that's where this technology can shine. And if a patient's telling me a story about maybe their smoking history, or maybe they're telling me a story about a traumatic event that happened many years ago, or about multiple surgeries that they've undertaken, I can then accurately capture that and document. And some of these social factors that determine the majority of factors that determine your health actually are social and factors that may not be under my control as a physician. And so if I can document those, I can then signal to whoever's paying for your care, hey, this population is dealing with a lot more homelessness than maybe a different population, or this population is dealing with food insecurity or transportation issues even. And so the more we can identify some of these factors that determine how complex a population is, the more then we can allocate resources to those populations. And so I think between ambient and some of these natural language processing capabilities, you can then support the way a physician's actually thinking and working, right? Like I don't think in the checkboxes in the order of the note, right? That note is maybe for data collection and documentation and billing purposes. Yeah. But the way that I'm thinking, it now supports the natural way that I'm thinking and operating, still capturing that data that's required, but just doing so in a more natural fashion that then supports me making better decisions with more data at my fingertips, and again with keeping the focus on the patient. So I think it makes us more efficient. It makes documentation capture more complete. We had an
more accurate as well, right? There isn't any chance of having a human error. So it's more accurate.
So that's interesting you say that, because I think in early pilots, everyone was thinking, well, the human is the sign of perfection and generative AI might hallucinate. Well, guess what? We omit things all the time and we introduce errors all the time. There are potential hallucinations and omissions with generative AI, but I think a lot of our early models are controlling for that for the most part. But you're exactly right. Like we have to capture things properly. And early on in one of the pilots, we had a physician tell me, whoa, this is capturing way more about the patient than I would typically capture. And, we don't want notes to get super long because they're already long enough, but we do want to capture the clinical nuggets and pieces that are going to determine how that care is paid for, how that care, how quality measurement is accurately measured and benchmarked, and then, how care is carried out during that hospital stay.
Absolutely. These are so important points, and small things like these can really, bring a lot of change and relief in anybody's life, I would say that. So also, if you have spoken about the technology now, so I know that I have been talking to the healthcare leaders and they're very cautious of technology. So they're less interested in the hype and more interested in proof, because this is not an industry where you can really go and do experimentation, right? This has to be very solid proof and accurate, safe, all of the compliance and guardrails to be in place. So what I'm noticing is that the pilot phase has gone now. People have started moving from pilot to the broader rollouts. And the first sign of success should be how clinicians and healthcare workers are feeling, right? Instead
Mhm.
of going into the financial metric chart. And I mean, that is also important. But what are the feelings of clinicians, workers, healthcare workers who are directly supporting it? So,
Mhm.
from what you have seen so far, what are the early signs or pilot results that have really stood out to you?
I mean, I'm so glad you framed it like that, because that's exactly early on what I was thinking. We everyone was talking about all this time savings, and
Mm.
everyone wants these like objective findings of time savings or improved revenue or something
Yeah.
like
All
this,
these common
just
KPIs.
to justify the expense. But I will tell you, the more powerful findings and outcomes we've seen are a little more qualitative or subjective, I guess you would say,
Mhm.
because we've seen many physicians talk about the reduced cognitive burden, and they even describe it as reduced anxiety, because I'm not going from patient room to patient room and having to remember what this patient told me 3 hours ago. And then I sit down to document and think, oh my gosh, what they told me something that justified me using
Mm.
this, medication. And like they're so this reduced anxiety, a little bit of time savings per note, reduced time after hours. You mentioned that time documenting after I leave clinic and go home for the evening. We're seeing reductions in that time, reductions
Mhm.
in the amount of time it takes me to close a note. So if it takes me 14 days, if you get too long to even sign your note in the clinic space, you may not be able to bill for it, and you definitely will forget what took place at that point. So we're seeing a lot of
Yeah.
same day note closure, but I think it's these subjective, qualitative pieces. We had I actually had a podcast myself, like you,
Mhm.
Jazz, but I had a guest from an academic medical center, and he said, now with this technology, I'm able to close my notes and I'm going home for dinner on time with my wife. I used to,
Wow.
my wife would text me at 5 o'clock, and I'd say, it might be another 30 minutes to an hour. And almost every day now I'm saying, I'll see you at 5 o'clock. And I think it's those pieces, back to all the clinician burnout struggles that we
Mhm.
see. If you can get people home for dinner and then not have 20 charts waiting for them to sign after that, I mean, will keep people in practice for many years after. I mean, I think that's another, we were talking about a supply problem, but it's also
Mhm.
part of the supply problem is a retirement problem, right? It's not just an
Yeah.
upstream training of health workers. You got to make sure people aren't retiring and leaving practice
Mhm.
earlier than they would like to be. And I think with these types of supports, maybe people are inspired to stay in practice longer, or even stay at their employer longer.
Yeah. I mean, this is incredible. I mean, whatever you said, completely align on that. And um, do you think somewhere the frameworks like DRGs, population segmentations, or risk stratifications, if AI is all across, so
Mhm.
putting AI on top of these can really help reduce down the burden. So, again, many clinicians I have spoken with, they are working incredibly, but then they have got incredible pressure. They have to
Mhm.
deal with the complex situations, limited time, high volumes, increase expectations around the outcomes, right? So it's in reality, it is not easy because you're dealing with the lives of people as well. You
Mhm.
you are a human as well, right? So what do you think frameworks like these can really help in getting things much sorted out? These are the frameworks which are existing from ages, but do
Mhm.
you think embedded AI can really help?
Definitely, that's the case. It really depends on how these population health methodologies are used. So you're talking about the diagnosis related groups, or DRGs. That
Mhm.
helps to risk adjust, or basically capture exactly what took place in a hospital admission, and then that helps determine how quality is measured for that type of admission, and helps direct payment for that admission, no matter
Mhm.
if there's a government payer or if there is a private payer for that admission. And defining the complexity of a population, whether it's for inpatient admissions, there are methodologies like EAPGs that risk adjust outpatient encounters, and there are risk adjustment methodologies like clinical risk groups that risk stratify populations, so down to an individual level, that can help support care coordination and really just capture that complexity of that patient population and help risk stratify for a bunch of purposes. The point of all these, though, I think it determines of how these are used, right? And everyone talks about value-based care. I think
Hmm.
that really the goal is like, how are you going to use all these methodologies to then incentivize what you want to happen in a system, right? I remember Don Berwick, a former administrator of CMS, said in a documentary called Escape Fire, I think it was, he said, I don't blame anyone in the system for doing what they're doing, because the system incentivizes them to do things. If you're a hospital, the system incentivizes you a fee-for-service system incentivizes you to fill hospital beds.
Mhm.
If you're a physician clinic, the fee-for-service system incentivizes procedures, visits, things like this. But if we can use these methodologies towards a purpose of paying for value, so incentivizing improved outcomes, incentivizing more efficient care, so lowering costs, basically, in my head, it's like doing the right thing for the patient, doing what you need to do to properly take care of that patient. No more, no less, basically. And if you can, by the way, part of the quadruple aim, improving outcomes, lowering costs, but improving the experience for physicians and improving the experience for patients. I think that's, if we can use these to incentivize value rather than volume, I think that's where the power lies. So it really depends where you insert AI. So right now, these methodologies are sophisticated things that have been built with clinical content experts over 40 years. And so these are very much rule-based systems, but the goal then is to apply AI in a targeted fashion to use these to kind of predict things. Can we predict when a patient might bounce back for a readmission 30 days after their hospital admission? Can we predict when a patient might have a complication during their hospital stay? There are many different things that we can start applying AI to. And so I think it really depends on the use case and what incentives you're using these to inject into the system.
Yeah. So right now, how it is happening, if, for example, two patients come of same symptoms, but one might show critical things later, which cannot be detected at that point of time. So right now, how it's happening, it's all ad hoc, first come, first base service, or is there any framework in place in general?
I mean, if you take a DRG, for example, that's basically capturing the complexity of a patient for that single hospital admission. So whether they're 20 days or 3 days, they leave the hospital with a DRG. And we have more advanced DRGs that have 4 levels of severity of illness. So if a 21-year-old comes in with an ankle fracture, it's probably very different than a 78-year-old who comes in with an ankle fracture who has diabetes, a higher severity level, most likely. And so through the documentation, you can capture diagnosis codes like ICD-10 codes. You can capture procedure codes like CPT codes. You can capture pharmaceutical information, some medications that were prescribed, all the kind of elements of that went into caring for that patient to then assign a DRG level. And the whole goal is to really anticipate, really to capture resource utilization for that single admission, but then to anticipate across a population for the coming year, what does the resource allocation need to be to care for that population coming up? And so, yeah, I'm not sure if that's getting exactly to that question, but that's the better you can capture what took place in that admission and what was required to care for that patient, how complex were they, the better
I think it is
you can pay.
Yeah. So, I mean, I'm pretty sure there might be a lot of other factors as well, like in the example which I gave. And based on that, if there is no framework, it's all up to the healthcare worker and decide that who to treat first, right? It is, again, a manual task. And
yeah. So, that's an interesting point. So one of the things right now, there's a lot of manual information searching going on, right? Like if there's a triage system, like in a clinic, or if you're trying to care for a population at like a regional level or provincial level or something like this, that's one of the beauties of risk stratifying a population, like our clinical risk groups can do, because you're right. Some populations need a lot of outreach, and like think at the beginning of the COVID pandemic, who needs outreach to say, hey, you really need an N95 mask. Hey, you really need to distance yourself. What can we do to support you in distancing yourself? And that's something like if you have got a sophisticated risk stratification tool, you can look at historical data and say, hey, these are our 10 sickest patients. Let's be calling them every other day during a COVID pandemic, make sure they have what they need. And if these are super healthy patients, we might just send them a text message versus, doing something higher touch, like calling them or even going to their home. So I think these are the tools that you can have in place. And like you said, inject AI maybe to start thinking about, hey, this is a complex population. This is maybe a very urban area they're living in without access to, healthy foods or something, without access to transportation. Like, what resources can we get to them to better care for them? And then I think that just goes back to the value-based incentives like we were talking about. If we're paying to improve outcomes and lower costs, then healthcare teams are incentivized to really care for that team, pay attention to those sicker patients, make sure they're getting what they need.
Yeah. And also one challenge I keep hearing about healthcare industry is that the population health insights live in the dashboards, but doesn't always translate into the actions, right? So platforms that embed intelligence directly into the workflows are where I see most the traction is. So how is Solventum's HIS, health information system platforms, are really enabling data-driven prioritization?
That's a key piece, because if you expect frontline health workers to act on something, you've got to make it easy for them to gather those insights and put it right in front of them. And so we think a lot about what does the user interface need to be for the physician? Where are they thinking about certain pieces of information? When do we show them something versus, is it while they're documenting or after they're documenting? So right now we have a coding and CDI platform that the majority of US hospitals use. That's kind of on a back end, right? Coders and CDI teams are working in that, using data to see what are some gaps in documentation. What is the illness burden of this specific hospital, let's say? And then they might send information to the physician to ask for more information or a query. And those types of queries, that's exactly what you're getting at. Like, how do you put some of that information in front of them to get them to see it at the right time? One thing I would argue is not the right answer is to put it in their in-basket. So the EHR in-basket, I'm not sure if you've had people on this podcast talking about that, but it's a major thorn in physician's side, right? I might have 100 messages there when I start my workday. And, some are like Flonase nose spray refills. Some are crushing chest pain. And then some are queries for information from CDI teams. There's very different types of messages in there from patients. There might be a holiday message in there too, right? So it's like right now there are tools that are trying to triage these so I can see the most urgent ones first. I can tell you from many physicians that CDI content sometimes is pretty low priority and something they might skip over. And so we try to think about how do you put that in front of the user interface at the right time so they can see, hey, your patient's intubated in the ICU, so they're quite sick, but you haven't said anything about them having respiratory failure. And so there needs to be more documentation on your board to capture that. So I think that's one of the main places where we use our applications that sit on top of the EHR and are right in front of the phishician, but are trying to be respectful of the physician's thought processes, right? Like, don't be in front of their face. Don't make it stop. Make it something they can look at when the time is right. And so that's something we continue to be thoughtful about with any strategy. As we're putting a lot more AI into CAPD and coding tools, but we're being super thoughtful about, like, how are we going to put that in front of the clinicians to drive action? Because you're right. Some of that population health data, payers may have it, organizational leaders may have it, but if the frontline clinicians don't have that right information at the right time, they're not going to be able to make the right decisions. I think so many times in practice, a couple examples I'll give you. One is GoodRx is a great website right now where it tells you if the drug you need, where's the cheapest one at what pharmacy. And I can tell you most frontline physicians still don't have easy access to that information in their EHR, which is crazy. Like 10 years ago, I was like, all I want, a patient would ask me, where's the cheapest place to send my lisinopril refill? I'm like, I don't know. And like, that is crazy that a frontline physician would. The other example is imaging. If I send you to a large hospital system, your imaging is going to cost maybe 10 to 15x an imaging of a smaller imaging center. And so there are some, it depends on where you live and where you work, but like, I don't have that information. I would have no idea. The payers have that information. And so I think there are ways that we can partner to get that right data in front of physicians to then send patients to the places that either are the cheapest or the most convenient for them, right? It may depend, like if all of their care is at a larger health system, that makes sense for them to go get their imaging there. If their care, if they've got flexibility and they just want simply the cheapest place, we just need that data in front of physicians so they can help with that more kind of complete decision making with their patients.
Yeah, absolutely. I have two questions. One is, how many patients in general, right? How many patients a doctor see in a day?
Gosh, that depends on a specialty. So in primary care, in primary care, I would say it's anywhere from 15 to 25 would be an average.
Okay, that's huge. Or it depends. It might also depend on the season as well, right? Sometimes it's flu season more.
That's exactly right. So complex follow-ups, new patients, mental health visits.
And how many patients are being tagged to the doctor, to one physician?
Oh gosh, and that varies from 600 to 3,000.
Is it?
Yeah. So it really depends. Back 10 years ago, 2,500 to 3,000 was a number that you would see as like a target practice area. There's a whole new wave of direct primary care practices that have, I think their goal is 600, 500 patients. And so but it depends again on the support systems, right? I think you're seeing this wave in primary care a lot of advanced practice clinicians. So NPs and PAs are supporting those practices, a lot of AI and tech solutions. I can take care of a bigger population if I've got the support staff and technology to support that.
Yeah, absolutely. But it's a big number again.
Yeah. Yeah.
Yeah, I was thinking like, maybe 100, 150, but it's
Oh
3,000.
gosh.
It's
Yeah, no. And I think and so that's back to the incentives. If you're expecting me to like proactively care for 3,000 people, you really need to be staffed appropriately. And that's usually like a physician and a medical assistant caring for that many people. So I think if you are in my, daydream, I would have a practice with a registered dietitian, a psychotherapist, a dentist, maybe a physiotherapist or chiropractor. I mean, you could have all these teammates, and I've seen this done in the employer-based space. Well, some large employers are taking control of their primary care and putting together multidisciplinary practices for this reason, because we know there's so many things that patients need to get better, and a lot of times a single physician can't solve all those, of course.
Yeah. Travis, you touch base on the data, right? There is a lot of data across in overall healthcare system, right? And AI is moving quickly into the clinical settings. But what I hear from most clinicians, healthcare workers, is that this isn't a resistant, it's about desire for clarity and trust, right? When we say that it's not getting adaptive, people are not adapting it. So it's like they want more clarity, more trust, more guardrails across us. So, and also they want that AI that fits naturally into their workflow. And that should be very transparent, supports the decision without actually, making uncertainties or risks. And from your perspective, tell me, what does trustworthy, practical AI really looks like in clinical environment? You can give one or two examples.
Sure. That is a really tough question, and that has just changed dramatically in the last 3 years, right? With generative AI becoming so popularized with ChatGPT and all these other solutions now, it is. I think we're at this messy phase right now where there are so many powerful solutions, yet the solutions vary widely, and the physician's level of trust and skepticism varies widely, right? There was a great article 2 years ago I love to cite where like hospital leaders are pumped about AI, frontline clinicians super skeptical. And so there needs to be a way to kind of bring those two attitudes maybe to a compromise. But to get trust, I think there's a couple things. One big thing is explainability, right? If AI is used for a certain type of model or decision that's put in front of physicians, there has to be a way to explain it. And there are many solutions right now that, and similar to our documentation solution, where you can basically cite evidence, like where did this come from in the conversation? If I can scroll over, and in clinical decision support tools, I've seen this done well, where I can roll over something and see the citation, like this is where this recommendation came from. And so now in this phase of generative AI, and who knows what it'll look like in 10 years, physicians need that explainability for now. And it's because all these AI models are different, right? You've got sepsis prediction models, you've got readmission prediction models, you've got all kinds of different measures and like simple calculators, like risk of hospitalization from COVID, risk of death from pneumonia, all these different calculators and risk prediction models that you need. There needs to be some kind of explainability and transparency. And that's one of these kind of responsible AI for physicians. And so that is one of the big things that we understand. I think thinking about these solutions and models need to be easy for the physician to use and integrate into their day-to-day as well. So many applications need another app on my phone or another web browser. And the majority of physicians' time or nurses' time is spent in the electronic health record. And so anytime you have to pop out to different applications to use different models, it's probably not going to be utilized very well. So I think some of the adoption, the learnings from adoption require a lot of thought about some of the upstream principles of change management to prepare clinicians about what's coming. And ideally, it's something clinicians are asking.
Is it not happening right now? I mean, the clinicians are not made aware before the things are getting developed, or I believe these are all different silos happening.
Yeah, there's a huge mix out there, right? Because there are startups that have created incredible, even like agentic AI solutions to support office practices, for example. And then there are large, corporations like ourselves and everything in between that have created these different models, different solutions, different tech that can kind of sit on top of the EHR, support practices. And so I think now you've got AI being infused into almost every bit of
everywhere.
our day-to-day work that, if it's explainable or if it's fair or unbiased, like those are things that like, I think we're quickly maybe already to this point where you can't research how every single AI model was built that you're using. And so I think that's why a lot of people are skeptical right now, is that we're kind of shoving this on people to say, hey, this is going to improve your productivity. And I think that's one reason for skepticism. So, perhaps moving a little slower before we, go off to the races would help in some cases.
Yeah, absolutely. And I think it comes back to the same question that if you want more participation from healthcare workers in the initial stage, they need to set free, right?
Mm-hmm.
They need to have some time. They need to have some breathing space where they can go and explore things. Right now, they are so overburdened that, thinking about something else is not even their secondary choice, right? The primary focus is to serve, to make sure people are alive, people are in the good health. So again, I think it's a circle, vicious circle, which keeps on moving. So unless we give some time, some spare time, and some breathing space to the doctors.
The circle you describe, we affectionately call the hamster wheel, right? Like you feel like you're constantly working, without any shift to that, right? Every day you're seeing 20 patients, and it's just, it can be exhausting. And so I think a little bit of autonomy in your practice and a little bit of time, like you mentioned, just to kind of research some of those tools or maybe play with some of the tools to see how it's going to improve your workday, can go a really long way. And people are coming to that realization. I mean, like back to the burnout discussion, you see chief wellness officers and all kinds of different organizations really thinking creatively about how to solve this.
Yeah, let's be hopeful for the future.
Sure.
So from your experience, what do you think that health systems need to do differently to make, to have a better collaboration between the clinicians, leaders, technology teams, so that they can, have clinician-facing technology adopted properly?
Yeah. I think it comes down to really buy-in. I mean, and that is getting feedback from clinical teams, being really crisp on the problems that they're having on the day-to-day basis. Because if you're coming to them with shiny solutions, but it's kind of like a fifth tier problem, like they're not going to adopt it or use it. So I think being crisp on the problem, that takes spending time with them to really understand what are the pain points, what are the things that they're seeing on a day-to-day basis in the EHR, for example, and then getting feedback along the way, right? Like if you deploy something, if you're really passionate about it in IT, frontline clinicians may not be that passionate about it, but they'll give you honest feedback about, hey, this is really not working, this is working. And the times when those are heard, we can solve things really quickly. And I think that's been the fun thing at the Solventum level is we've got a bunch of teammates. We have solution advisors or adoption specialists is what we used to call them, where they go really, they're with customers beyond the implementation to say, hey, how are you using our solution now? What are you trying to do differently that's different from 6 months ago?
That's
we could probably fix something like that with you. And so it's working alongside the customer. The Solventum tagline is like, we're constantly solving for you. And I love that because it really shows that we're working alongside our customers and really the true end customer, the clinicians, to say, how are you going to use some of these solutions? And how is that going to then connect back to our CDI and coding solutions that you may feel disconnected from, but it's still important for that population health data capture.
That's great. I think that's getting feedback and then, re-implementing things to the product. That is the best thing any product company can do, irrespective of wherever they are working.
It's wild the amount of differences out there, right? Like some think as long as it's shiny and slick, it's going to do the trick. And you just need so many layers, especially at large organizations. And I think there's a way to do that. And then, on the customer side, we've had some customers that are super thoughtful about having their physician leaders be the messengers, be the champions of some of these new technologies and the changes. And that's like a key change management element, right? Getting people interested in using the whatever new solution is coming. So a lot of these CDI tools, again, not one of the physician's top priorities sometime, but if you can message to them like, hey, this is going to impact how your quality scores look to external entities, like, oh, okay, all of a sudden documentation becomes quite exciting. So I think there are ways to communicate, and you have to think about the message, but also the messenger and the systems that incentives that support that in the system.
Absolutely. And Travis, as we are coming to the end of the podcast, I would like to know what are the big breakthroughs you believe will meaningfully improve clinician well-being, patient access, and quality care overall?
There are a lot of things we're excited about. AI is allowing us to modernize our tech platform, like I'm sure your team understands quite well. And that's allowing us to move faster in a lot of ways, move faster in looking for potential root causes for quality issues, and move faster in payment for health services, right? Like, we can look at maybe automating some repeat or more simple coding cases and get those paid quickly. Maybe we can bring together providers and payers to agree on paradigm or frameworks, as you mentioned, about let's pay for the simple cases. Let's take some of the time intensive steps out of the process to get people paid for the services they're rendering. And then maybe remove some of the burden from clinicians as well, who are having to maybe document or answer queries for information or fill out prior authorization letters or rebut denials. And that then brings me kind of more to the front end clinician pieces. There's so much that can be done with generative AI. We're playing around with all kinds of tools that are super fun, that are writing letters from primary care physicians to their specialists, writing discharge letters from hospital discharges in the UK and in other systems, using generative AI to translate patient education materials either to a different reading level or to a different language. Like, these are all major barriers to proper care that now generative AI is allowing us to do this. And then look and try to predict, back to the payment side, predict, and gather what information you need for prior authorization for services, and then predict what hospitalizations or what payment might be denied and for what reason. So that clinicians can gather the proper documentation the first time around in the chart, rather than having to go back and forth, because that's super wasteful. It's burdensome on physicians, burdensome on the health systems, and it's a time-intensive process for payers as well. And so I think there are places where we could reduce some inefficiencies and wasted time by trying to automate some of the low-hanging fruit and some of the simple cases as far as payments concerned, and some of the quality reporting, automating some of that. But then identifying, even in those complex cases, hey, what information is going to be needed to predict this denial? Make sure this payment happens on time. Make sure this patient gets what they need, because there's a human impact to this that I think is major. I've heard about it at multiple conferences, these stories of patients either not getting their care covered, or just the patient's experience with the system was very complicated. And so if there's a way that AI can improve their experience by reducing inefficiencies on our side, it could be a win-win-win.
Absolutely. I think claim management is one of the areas where it is touching all the parties, and it is so complex and manual now. If it is streamlined, AI helps, then definitely it is going to be a win-win situation. So I was talking to one of the leaders, and then he said that generally it takes around 60 to 80 or sometimes 120 days to get a process claim completely settled down, and in between you have denials, or in between you have back and forth, it extends further. So I mean, you correctly mentioned that if there are a lot of places where the manual works go on, and if those can be automated, could be wonderful for all the parties.
Right, and I think you can automate some of that. And for the CDI and coding teams in the background, the clinicians don't see the work that they're doing. They're doing a ton of work, and they could take in, what are these written policies? What are the policies from commercial payers, from governments, to then prioritize their work, right? Let's automate some of the low-hanging fruit of the CDI and coding teams, but then let's let them focus on some of these complex cases that really does require their attention. So having them focus on some of these really difficult cases, and some of the communications with the payers, to make sure that the humans are spending their time where we need the humans to spend their time, rather than on some of the simpler cases that we could probably automate based on written policies that are out there.
It was wonderful talking to you and knowing more about you, knowing the challenges and the developments going on and all of that. So thank you so much for coming onto the podcast.
Cool. Thanks, Jazz. Thank you for having me. I really appreciate the conversation.